So today's called profiting from PBM. So it seems wise to start with a bit about what PBM is and also why it's important to a BMS. So just to set the scene a little bit, probably back in the 1990s, we were seeing a year-on-year increase in blood use. And there was a general feeling that everybody needed a normal hemoglobin. That was kind of best practice. And then at the same time, we had the birth of the SHOT reporting scheme in 1996, and the appreciation that transfusion was a risky procedure. And people started to question then, well, how much blood do people really need? Does everyone really need a hemoglobin of 120, 130? And this was a trial in 1999, which was really a seminal work that started off the move towards blood conservation. So this was a large trial in over 600 patients in ITU, where they randomized people to giving them a blood transfusion either when their hemoglobin dropped below 70, that was the restrictive threshold, or above 100, so that was the liberal threshold. And they compared various outcomes in those patients and found that overall, at 30 days, there was no difference in mortality between those two transfusion regimes. As you'd imagine, fewer people were transfused in the restrictive arm. And there are actually some patients who seem to do better with the restrictive strategy. So particularly those who are less severely ill and a bit younger. And when they looked at just mortality within the hospital, that was also significantly lower in patients who received less blood. And this was really a surprising finding at the time and stimulated a lot more work following on from that. That's just a visual of that the trial I was speaking about, so the TRIC trial, showing that patients who were transfused with a restrictive strategy in ITU had certainly no worse outcomes and possibly better outcomes than patients who were transfused liberally. We go on to the next slide. And that prompted a lot of other work and studies in different scenarios. And this was a meta-analysis of various RCTs that NICE reviewed when they were creating their guidance about blood transfusion. And this was 31 different studies. And overall, they didn't find any difference in clinical outcomes, including mortality, cardiac events, length of stay, and other complications in a restrictive versus a liberal strategy. Fewer patients needed transfusion in the restrictive group. And if you look at the bottom, what was really key, patients who received more transfusion had more transfusion-related adverse events, particularly TACO, so transfusion-associated circulatory overload, which we're recognizing as one of the key complications of transfusion. So if you move on, and this was one of the factors that really prompted new guidelines and recommendations around really wise and appropriate use of blood, and only using blood transfusion when it was really necessary. And that's developed over the years as researchers moved on. We started off with a couple of circulars which were called appropriate use of blood, and then moved on in the 2012 was when patient blood management was adopted as a concept and a term, and the first guidance around PBM was issued out to hospitals in 2014. So what is PBM? If you go to the next slide. So here's the wordy definition. And I'll just pull out a few key words. So the idea of PBM is that it's multidisciplinary and evidence-based. So there's this reason why we're making these recommendations. And it's about optimizing the patient's care. So really thinking about all aspects of their care and avoiding inappropriate use of blood components. So it's not just about transfusing less, it's really about transfusing wisely and making sure that patients who need blood get it when they need it, but that it's not used when it's not needed. And key to the concept of PBM is the patient. So the point is that patient blood management puts the patient at the centre and really thinks about all the aspects of their care, and more than just their medical issues, social issues, and the patient's own wishes. And that's really where PBM differs from previous strategies around blood conservation. So if you move on, most often we apply PBM to the surgical population because surgical patients are the ones who have a predictable need for transfusion, which is potentially preventable. And we talk about the 3 pillars of PBM, which you can think of as a kind of before, during, and after. So before surgery, we try and first of all detect anemia and see what we can do to correct it preoperatively, and that's often with things like iron and maybe the hormone erythropoietin for certain populations. During an operation, we try and minimize blood loss, and that can be around different surgical techniques. So a lot has changed in recent years around the way surgery is done, a lot of keyhole surgery and bloodless surgery. We can use cell salvage to collect patients' own blood, which can be returned to them either during the operation or afterwards. Tranexamic acid is a drug that helps blood clots stay strong and can reduce blood loss. And we try and make sure that patients who are on blood thinners, so aspirin or other anticoagulants, have them stopped in a timely fashion beforehand. And then after surgery, and this is maybe where the laboratory and BMSs come in more, is really using blood wisely. So does a patient really need a transfusion? Can they tolerate their anemia without any clinical consequences? And that's where we recommend restrictive triggers where appropriate, giving a single unit of blood at a time and then reassessing, and maybe thinking about iron or other alternatives to help them recover faster from their anemia. So lots of words there, but has it had any impact on blood use? So you move to the next slide. So if you look at the start of that graph, in the mid to late 90s, that rise year on year on blood use started to flatten out in the early 2000s. And since then, we've seen a progressive decline in blood use. And that's really the result of improvements in new research, in guidelines, working together with clinical teams, particularly surgeons and anaesthetists, and some really good education of clinicians and the laboratory. So if you move on. Now, what does this all mean for a BMS? I've talked about lots of clinical things. Does this mean that we're not really using blood anymore? So you can all just sit back and relax? I suspect you'd maybe say no. Or, next slide. Does it mean you should be the riot police, refusing to let anybody have blood unless they're actually on death's door? Probably not the best way forward either. There's a happy medium then. And you are the gatekeepers. You're the final sort of sign off. You're the ones who are going to let the blood products out. And I think that's a really useful opportunity to be starting a dialogue. So remember, you as BMSs probably know a lot more about blood transfusion than most clinicians phoning you. But then the clinician has the patient in front of them and knows their history, their current status, their scenario. And it's a really important job to put those two skills together. If you move on. And I think the role of the BMS is to help clinicians to stop and think about whether a patient really needs a transfusion, and maybe signposting them towards other sources of information, which might be your haematology registrar or consultant. And once they've learned once, we hope that our clinicians will also know what to do the next time. And I hope by the end of this morning, you'll feel a bit more confident in starting up that dialogue and helping our clinicians to stop and think about transfusion. So good luck and thank you very much. Happy to take any questions.